Welcome back to the Deep Dive, where we transform complex, dense scientific and clinical data into immediately usable knowledge.
Whoa.
Today, we aren't just summarizing papers. We are really crafting the foundation for confident, high-stakes decision-making.
That's the goal.
If you are preparing for a major theory examination or maybe a clinical viva voce, this deep dive is absolutely custom-built for you.
That's absolutely right. Our mission today is to move the discussion of general anesthesia, or GA, past the sort of procedural steps and into the fundamental rationale.
Oh, why?
Exactly. We're looking at why we choose specific drug combinations, how they interact at the molecular level, and how you can translate that deep understanding into confidently answering those crucial 10 to 20 mark theory questions.
And more importantly, how it informs your decisions in the OR.
And more importantly, informing your minute-by-minute titration decisions in the operating theater.
Okay, so let's unpack the core problem that really mandates our entire practice. Why do we rely on balanced anesthesia or BA at all? If we have these incredibly potent agents, propofol, sevoflurane, why can't we just push a single powerful drug to achieve the state we need?
It's a great question.
The concept of balance exists to solve a fundamental physiological trade-off, doesn't it?
It absolutely does. The core dilemma facing anesthesiologists is rooted in toxicity and physiological trespass.
Okay.
If you attempt to push a single agent, whether it's a volatile anesthetic or an IV drug, to a dose that's high enough to guarantee all the necessary features of surgery,
Like total immobility.
specifically surgical immobility, you will almost inevitably introduce unacceptable levels of side effects.
And that usually means hemodynamics.
It almost always manifests as profound excessive hemodynamic depression. You're compromising blood pressure, cardiac output, and vital organ perfusion.
So balanced anesthesia is the workaround.
It's the ingenious and principled approach we've devised to circumvent this physiological ceiling of toxicity. We're trying to achieve maximum therapeutic benefit with minimum physiological cost.
So before we look at the solution, let's really define the problem space. When we talk about general anesthesia, what are the absolute non-negotiable goals we're aiming for?
Right.
The 4 cardinal features that must be achieved reliably every single time.
We aim for 4 essential components. First and foremost, the patient must experience a loss of all sensation, particularly pain. This is analgesia.
Number 1.
Second, we require sleep or unconsciousness coupled with amnesia. The patient has to be unaware of the procedure and, critically, unable to form any recall of the events.
And third is movement.
Third, we need immobility and muscle relaxation. This is just essential for safe intubation, achieving the necessary surgical field, and ensuring the patient doesn't react to instrumentation.
And the 4th feature often links the physical state back to that physiological cost we mentioned.
Precisely. The 4th is the abolition of somatic and autonomic reflexes.
What does that mean in practice?
It means suppressing the body's reflexive and often dangerous sympathetic response to surgical stimulation. That surge in heart rate and blood pressure that can be so detrimental, especially in fragile patients.
And balanced anesthesia, BA, is the modern methodology designed to hit all 4 of those targets reliably and safely.
Yes, and without forcing one drug to carry the entire burden.
That's the key.
That is the perfect summary. The modern definition of balanced anesthesia is the principal practice of achieving these 4 cardinal features by using a meticulously orchestrated combination of inhaled and intravenous agents.
So it's multimodal by definition.
By definition. And the key is that each agent is deliberately chosen for a discrete complementary purpose.
This moves beyond simply mixing drugs. So when an examiner asks about the core philosophy, what specific concept are they really looking for?
They want you to define BA as a principled approach to producing a drug-induced reversible coma. The core philosophy centers on using a balance of agents and techniques to selectively target and direct different components of the anesthetic state.
Analgesia, amnesia, immobility.
Exactly, all of them, while at the same time aggressively managing and maintaining physiological homeostasis.
So the balance isn't just pharmacological.
No, it's physiological as well.
This approach represents really centuries of evolution. We've moved so far away from those early single-agent techniques.
We have. And the history really drives home the necessity of this balance.
How so?
Well, when Oliver Wendell Holmes coined the term anesthesia back in 1846, the goal was merely amnesia, analgesia, and narcosis.
That was it.
That was it. And those early single-agent attempts, like using pure diethyl ether, demonstrated massive physiological trespass. To get the surgical depth you needed, the immobility, you were often pushing the patient to the very brink of circulatory collapse.
So the shift to BA was a clinical necessity.
It was driven by clinical reality. We had to find a way to deliver surgical depth with minimal physiological disruption. We had to break that single drug link between surgical efficacy and systemic toxicity.
And this brings us to a concept that is absolutely critical for MD-level understanding, BA as applied drug interaction.
This is a high-yield concept for any theory or Viva exam. You have to understand this.
So what's the core idea?
Modern anesthesia is the practice of applied drug interactions. You are seldom, if ever, administering a hypnotic, an analgesic, or a muscle relaxant in true isolation.
You're always combining them.
Always. And their combined effect is rarely the simple addition of their individual effect.
And the aim is to leverage this interaction for maximal benefit. We're talking about synergism.
Exactly. We strive for synergism, which means the combined effect is mathematically greater than the sum of the individual effects.
Right.
A classic example is the interaction between hypnotics and opioids. This synergy lets us drastically reduce the required doses of each agent.
And by reducing the dose.
By reducing the dose, you minimize dose-dependent toxicity, like respiratory depression, and crucially, that hemodynamic depression we started with. This is the mechanism behind the highly desirable MAC sparing effect when you add opioids to volatile agents.
Can you give us a practical analogy for what that MS sparing effect truly means in the operating room?
Sure. Think of it this way. If you had to achieve immobility using sevoflurane alone, you might need a concentration of, say, 2.0 MSC.
Which would be huge.
Huge. And it would almost certainly drop the patient's mean arterial pressure, their MAP, to 40 millimilliJACE, risking ischemia.
Okay.
But by introducing a modest dose of fentanyl, you leverage that synergy and can reduce the sevoflurane requirement to perhaps 0.7 or 0.8 MSC.
That's a massive cut.
It's a 60% cut in the volatile dose. And that reduction is the difference between a potentially toxic technique and a hemodynamically stable, safe one. The synergy just transforms the efficacy toxicity curve. To organize your thoughts for an extended answer, especially for a 10-mark question, I always recommend using the 6 pillars framework. It just ensures you have comprehensive coverage.
Okay, so let's walk through that framework. We have 1, hypnosis or unconsciousness, 2, analgesia, 3, amnesia, 4, muscle relaxation, 5, autonomic stability, and 6, homeostasis. Let's start with the cognitive elements, hypnosis and amnesia. What are the goals there?
The goals here are complex. We need loss of cognitive function, unawareness, and critically, the inability to form an emotional response to stimulation, which results in no conscious recall.
When examiners push for detail on this, they often want to know the mechanism. So let's take benzodiazepines, a key part of premedication. How do they provide such reliable amnesia?
Benzodiazepines, like midazolam, are staples because they offer powerful anxiolytic, sedative, hypnotic, and most notably, anterograde amnesic properties.
And this is at the receptor level.
This is achieved by binding to the GABA-A receptor. And for real depth and precision, you need to remember that the alpha-1 subunit of this receptor is primarily implicated in mediating those key effects, sedation, amnesia, and anticonvulsant activity.
So by targeting that specific subunit.
By targeting that specific subunit, we can predictably erase the memory of the events without requiring excessive cardiorespiratory depression.
Okay, next up, the physical requirements. Analgesia and muscle relaxation. Opioids are really the centerpiece of analgesia and BA.
They are non-negotiable. The inclusion of an opioid serves multiple synergistic purposes. It addresses preoperative pain, it reduces the patient's somatic and autonomic responses to the surgical stimuli itself,
And it lowers the dose of everything else.
and as we discussed, it allows us to substantially lower the required doses of the hypnotic agents. In essence, the opioid handles the pain input, freeing the hypnotic to focus solely on unconsciousness.
Right. And muscle relaxation, the fourth pillar, is vital for the surgical field.
It's crucial for intubation and for achieving optimal operating conditions, especially in complex abdominal or thoracic procedures. And this relies on neuromuscular blocking agents, almost always non-depolarizing agents in a controlled BA setting.
But there's a key distinction here, isn't there?
Yes, and this is a key exam detail. You have to remember that the abolition of the purposeful withdrawal reflex, the reflex immobility we require, is linked to the spinal cord action of the inhaled anesthetic, not just the paralysis provided by the muscle relaxant.
Interesting. So that tells you something about the true depth of the anesthetic.
It helps us understand the true depth, absolutely.
Let's move to the critical fifth pillar, autonomic stability, or stress attenuation. Why is this so crucial, especially for the high-risk patient?
Because surgery, particularly major trauma, initiates a profound systemic stress response.
Right.
This is characterized by the release of stress mediators, catecholamines, cortisol, ADH, glucagon, driving the patient into a hypermetabolic catabolic state.
And clinically, what does that look like?
Clinically, this means hyperglycemia, a negative nitrogen balance, and fluid and sodium retention, all of which severely increases myocardial work and oxygen consumption.
And I'm guessing the intensity of his response is directly related to the trauma itself?
Absolutely. The higher the surgical trauma, the more intense and prolonged that neuroendocrine stress cascade becomes.
And BA actively counters this.
It does. The application of high doses of potent opioids like fentanyl or sufentanil is exceptionally effective at inhibiting the hypothalamic pituitary adrenal or HPA axis. This suppresses the release of those damaging stress hormones.
And that's central to protecting the heart.
It is central to maintaining stable hemodynamics and protecting the heart in ischemic patients.
So how does this approach stack up against what's considered the gold standard for stress attenuation?
The gold standard remains regional anesthesia, specifically central neural blockade like an epidural or spinal.
Why is that?
Because regional anesthesia physically prevents the afferent neural input, the pain signal, from reaching the central nervous system entirely. This block of the ascending pathway is the most successful method of reducing the neuroendocrine stress response.
Is there a Viva detail we should remember here?
Yes. For a Viva detail, remember that some studies suggest lumbar epidurals are often more effective than thoracic epidurals.
Why would that be?
Possibly because achieving a complete block of the complex lumbar autonomic nerves with a thoracic catheter could just be more challenging.
And finally, Pillar 6, homeostasis. This is arguably the most fundamental component of patient safety, but it's often overlooked in pharmacology discussions.
Homeostasis, cardiopulmonary, and fluid management is the bedrock upon which the other 5 pillars stand. The primary goal is the minute-to-minute maintenance of tissue oxygen delivery.
Which is constantly under threat from our drugs.
It's constantly challenged by the vasodilation and myocardial depression caused by our hypnotic agents. When we use low-dose volatiles in BA, we are managing that risk, but even a low MSH can cause peripheral vasodilation requiring vigilance.
What about temperature management in this context?
Temperature control is inextricably linked to homeostasis, and it's a major factor in patient outcome, often tested heavily.
Right.
General anesthesia universally impairs thermoregulation. It leads to core heat redistribution and often hypothermia.
And the consequences of that can be severe.
Severe hypothermia increases the risk of coagulation disorders, it prolongs drug metabolism, it increases the risk of surgical site infection, and it dramatically worsens recovery.
So active warming is mandatory.
In BA, the selection of drugs, especially the potent vasodilator inhalational agents, combined with the cold environment of the operating room, necessitates the mandatory use of active warming devices. Failure to ensure strict temperature control is a failure of the homeostasis pillar. To really justify the balance, you have to understand that the state of anesthesia is not a monolithic switch. It's not on-off. It's a collection of separable functions controlled by different regions of the brain and spinal cord.
Okay, so let's unpack that concept. Anesthesia is a composite neuropharmacologic state, and this basically dismantles the old unitary hypothesis.
Absolutely. The state we induce is composed of several separable and partially independent components: amnesia, unconsciousness, immobility.
And they all have different control centers.
They are mediated by distinct, though sometimes overlapping, mechanisms in different regions of the central nervous system. This regional specificity is why balanced anesthesia works.
Because you can target them individually.
We can use one drug to target the spinal cord for immobility and a different, perhaps less cardiotoxic drug to target the cortex for amnesia.
Let's detail those specific sites of action, the loci that examiners use to differentiate candidates. Let's start with immobility and the MXC concept.
Immobility, which is the prevention of purposeful movement in response to a surgical incision, that's what we quantify with MXC, is mediated overwhelmingly at the level of the spinal cord.
The spinal cord.
Specifically, we were suppressing the efferent or motor output from the ventral horn neurons.
Wait, that flips the script entirely. If immobility isn't about consciousness, does that mean our typical clinical signs of depth, like heart rate or blood pressure changes, are sometimes misleading when we're just looking for actual immobility?
That is the critical insight. Hemodynamic signs primarily reflect the autonomic response, which is often centrally mediated. Immobility, however, is a spinal phenomenon.
And there's proof for this.
Yes, the classic high-yield exam proof comes from animal studies where the entire cerebral cortex was removed, yet the potency of the inhaled anesthetics, the MAC, remained unchanged.
Wow.
This demonstrates definitively that the mechanism of movement suppression resides primarily in the spinal cord, independent of the cortex, thalamus, and the RAS.
So if immobility is spinal, then unconsciousness and amnesia must be supraspinal.
Precisely. Unconsciousness, sedation, and hypnosis involve supraspinal mechanisms. Key structures here include the cerebral cortex, the thalamus, which acts as the major relay center for sensory input, and the reticular activating system, or RAS, which is crucial for overall arousal.
And amnesia.
Amnesia, specifically the loss of the ability to form new memories, is often cited as the most sensitive anesthetic endpoint. It likely involves the hippocampus, amygdala, and mediotemporal lobe structures responsible for memory consolidation.
Okay, let's move to the molecular level. We know the unitary hypothesis that all anesthetics work the same way via non-specific lipid membrane effects is dead. What is the modern agent-specific theory?
The agent-specific theory states that general anesthetics bind directly to specific amphiphilic cavities within target proteins. Their effects can't be explained by a single common molecular mechanism. They're achieved by different mechanisms for different drugs.
So what are the primary molecular targets for the desired inhibitory effects?
Our agents primarily enhance inhibitory synaptic transmission. Volatile agents and most IV hypnotics potentiate ligand-gated ion channels, primarily GABA-A receptors, the main inhibitory transmitter of the brain,
Right.
and lysine receptors, which are the main inhibitory transmitter in the spinal cord. Essentially, we are turning up the volume on the brain's braking system.
And on the flip side, we have to suppress the acceleration system, the excitatory neurotransmitter.
Exactly. Inhaled anesthetics and agents like propofol also suppress excitatory synaptic transmission. Propofol is known to reduce glutamate release presynaptically.
And what about the gases?
Critically, gaseous agents like nitrous oxide and xenon achieve a significant portion of their effect by inhibiting NMDA receptors, which are the key excitatory receptors in the brain. The effectiveness of PA relies on this dual action, enhancing inhibition and suppressing excitation simultaneously.
This molecular and regional specificity brings us back to that fundamental Viva gold point, the distinction between being merely sedated and genuinely anesthetized.
This is a critical nuance. Sedation, which is an arousable state, largely shares mechanisms with natural sleep. It involves the activation of the body's intrinsic sleep-promoting systems,
Which ones?
specifically neurons in the ventrolateral preoptic nucleus, the VLPO, and the median preoptic nucleus, or MNPO. Low doses of anesthetics, or agents like dexmedetomidine, induce this state. If you stimulate the patient, they can be aroused.
But surgical general anesthesia is the unarousable state.
That requires a much more profound disruption. General anesthesia requires additional complex mechanisms that involve simultaneously modulating neural circuits downstream of the simple sleep centers. We target the thalamocortical networks, the communication hubs between the thalamus and the cortex. Surgical doses disrupt the brain's capacity for complex, integrated information processing across vast regions, making arousal to even the strongest surgical stimuli impossible.
So it's a different level of intervention entirely.
It is. If sedation is merely dimming the lights, GA is disconnecting the master circuit breaker in the basement, preventing the signal from reaching the main room entirely.
Moving from the neurobiology to the application, we need to quantify the power of these interactions.
To succeed in BA, you must not just know that drugs interact, but how that interaction is quantified.
So if we know these drugs interact, how do we scientifically quantify that interaction beyond just observation? What's the metric?
We use isobolographic analysis. It's a graphical technique that plots the dose of drug A required against the dose of drug B required to achieve a single fixed effect. If the plotted line of combination doses falls below the line of simple addition, that confirms synergism. The effect achieved is greater than the sum of the individual parts. If it falls directly on the line, the effect is additive.
Isobolographic analysis is a big word. Can you give us a quick real-world analogy of how synergy shows up on that graph?
Sure. Imagine needing 10 units of drug effect. If drug A gives 5 and drug B gives 5, and you need 10 to reach the goal, that's additive.
Simple enough.
But if you combine only 3 units of drug A and 3 units of drug B, and that combination somehow gives you 10 units of effect, that's synergy.
I see.
The key is that you achieve the required outcome using dramatically less total substance, which directly translates into minimized side effects, less hypotension, less respiratory depression. Leveraging synergy is fundamental to BA.
Let's discuss the drug classes, starting with the cornerstone of pain management, opioids.
Opioids are essential. For exams, you want to categorize them. Synthetic opioids like fentanyl, remifentanil, and sufentanil are potent, fast-acting phenylpiperidine derivatives that act as full agonists.
And they work everywhere.
They suppress pain at the brain, spinal cord, and peripheral nervous system levels. The key distinction often tested relates to their pharmacokinetics, particularly the unique, extremely rapid metabolism of remifentanil
Right. It's metabolized by esterases.
by nonspecific plasma and tissue esterases, yes.
That makes remifentanil highly titratable, but also ephemeral, which has major implications for post-operative pain management, correct?
Exactly. Because remifentanil's effect vanishes almost instantly upon cessation, if it's used for maintenance, you must absolutely plan for replacing that analgesia with a long-acting opioid like morphine or hydromorphone before emergence.
Otherwise, it's a disaster.
Otherwise, the patient will wake up in severe pain and a sympathetic storm.
What is the mandatory complement to opioids in modern BA?
That is multimodal analgesia. This approach is defined as combining two or more analgesics with distinctly different mechanisms of action.
And the goal is opioid sparing.
The primary clinical goal is to improve pain relief, while concurrently aiming for a significant opioid-sparing effect, mitigating the major side effects of opioids like nausea, vomiting, ileus, and respiratory depression.
So what are the key non-opioid adjuncts we rely on, and how effective are they in sparing morphine?
We rely heavily on IV acetaminophen, or paracetamol, which is often a short-note topic itself. Also, NSAIDs, selective COX-2 inhibitors, ketamine, and lidocaine infusions.
And can you quantify that sparing effect?
Quantifying it is high yield. Studies show that adding IV paracetamol provides a morphine-sparing effect of approximately 15 to 20%.
Okay.
TOX2 inhibitors improve this to around 25%. However, combining regional blocks with systemic agents is often the most effective route, achieving excellent opioid sparing and superior analgesia.
Let's move to the hypnotic agents, propofol and the volatiles.
These really define the phases. Propofol or thiopentone are used for rapid, smooth IV induction. The volatile agents, sevoflurane, desflurane, isoflurane, are the maintenance backbone.
Yes, and BA.
In BA, maintenance typically uses the volatile agent at a very low MC, often 0.5 to 0.7, because we rely so heavily on that potent MAN-sparing effect with the supplemental opioids.
The finding of stereoselectivity provides profound evidence against the older unitary theories. How does that finding change how we approach new drug development?
It's a game changer. The discovery that certain anesthetics, like isoflurane, exhibit stereoselectivity.
Meaning one version of the molecule is stronger than its mirror image.
Exactly. One spatial configuration, or enantiomer, is significantly more potent than its mirror image. The dextrorotatory enantiomer of isoflurane is 53% more potent. This proves that the drug must be binding to a specific three-dimensional protein receptor site.
Which confirms the agent-specific theory.
It confirms the agent-specific theory and tells us that future drug development must target these specific binding pockets, not just nonspecific lipid membranes.
Let's look at the adjuncts used for stability and targeted sedation. Dexmedetomidine is a fascinating agent.
The alpha-2 agonists, primarily dexmedetomidine, are powerful tools. They provide arousable sedation, which is crucially different from GA via alpha-2 stimulation in the locus coeruleus.
And that profile is useful.
It offers robust anxiolysis and some analgesia. Importantly, it preserves the cerebral oxygen supply-demand ratio and reduces cerebral blood flow via vasoconstriction, making it highly desirable in neurosurgical and cardiac patients.
Finally, we have to revisit interactions, specifically a crucial warning about benzodiazepines.
Yes, this is a complex interaction. While benzodiazepines and opioids are markedly synergistic for the desired effects of hypnosis and depression of ventilation.
Meaning they potentiate each other dangerously?
They do, but evidence suggests that benzodiazepines may paradoxically reduce the analgesic actions of opioids. Yes. Clinically, this means you might achieve deeper sedation, but potentially less effective pain control, requiring very careful titration and monitoring. Always remember that BA is a landscape of complex, sometimes counterintuitive, pharmacodynamic interactions. So now we can map these components onto the clinical flow, which is a very common setup for a long theory question, demanding the rationale behind each phase.
We'll begin with the preoperative phase, optimization and pre-medication. The rationale is absolutely key here.
The goals are multifaceted. You're stabilizing the patient physiologically, providing robust anxiolysis, achieving sympathicolysis, reducing sympathetic tone, and starting the prevention of PONV.
And the drugs of choice.
Oral benzodiazepines, particularly midazolam, are the most common pre-medication choices. They offer reliable anxiolysis and the crucial benefit of endo-grade amnesia. This just ensures the patient has no recall of the pre-induction phase, which can be very stressful.
What about the high-risk patient, like the cardiac patient whose sympathetic tone is actually dangerous?
For cardiac patients or those with high sympathetic drive, pre-medication might include an alpha or beta blockade, like clonidine or atenolol.
And the rationale isn't just comfort.
No, it's physiological protection. We aim to blunt the potentially dangerous heart rate and hypertensive responses to the emotional stress of the waiting period and the physical stress of induction and laryngoscopy.
Okay, moving into the induction phase, the logic of drug selection is paramount, especially regarding hemodynamics.
The goal is a smooth, rapid induction while maintaining stable hemodynamics. This is where BA truly shines.
How so?
We use a potent, short-acting opioid like fentanyl or sufentanil alongside an IV anesthetic like propofol or etomidate. The opioid's primary role here is to blunt the intense hyperdynamic response, that surge in blood pressure and heart rate that is universally triggered by laryngoscopy and intubation.
Without that opioid, the patient's BP could spike dangerously.
It could. It absolutely could.
Once stable, we transition to maintenance, and this is the classic balance between IV and volatile approaches.
The BA standard is the combination. A volatile agent at a low MSE, around 0.5, supplemented by a potent narcotic and a non-detolerizing muscle relaxant. This leverages the reliability of the volatile for depth with the MSA-sparing and autonomic stability provided by the opioid.
Let's define the major alternative here. Total intravenous anesthesia, or TIVA.
TIVA is defined strictly as induction and maintenance using exclusively intravenous drugs with no inhalational agents whatsoever. That includes nitrous oxide. It is often tested against the BA standard.
So if BA is so flexible, why would a clinician choose TIVA? What are its superior advantages?
TIVA has compelling advantages. Reduced operating theater pollution, which is an occupational health concern. A generally lower incidence of postoperative nausea and vomiting, or PONV, compared to volatiles.
And it's better for the lungs.
It can improve ventilation perfusion, or VQ matching, which is beneficial in patients with existing lung disease. Also, TIVA generally provides more consistent hemodynamic control and is preferred when continuous neuromonitoring, like evoked potentials, is required, as volatiles can interfere with those signals.
Conversely, if synergy and stability are so strong in BA, what are the inherent disadvantages of TIVA that demand caution?
Well, TIVA's key limitation is that it violates the BA principle. No single intravenous agent provides all the necessary components. It always requires a complex combination, often relying on target-controlled infusion pumps.
Which introduces risk.
It introduces the risk of awareness if the IV line is compromised or the infusion fails. TIVA also carries a higher risk of early or late respiratory depression due to drug accumulation, requiring meticulous monitoring well into the recovery period.
Finally, emergence and recovery. A smooth transition seems to rely heavily on the analgesic component.
It requires meticulous planning. The moment we stop the hypnotic and paralyzing agents, the pain signals return aggressively.
So you have to be ahead of the pain.
Smooth emergence demands a robust multimodal analgesia plan that's ready to transition from intraoperative coverage. As we noted, if remifentanil was running, the clinician must ensure a bolus of a longer-acting opioid like morphine is given 20 to 30 minutes before the end of surgery to provide adequate postoperative analgesia.
And prevent a painful sympathetic emergence.
Absolutely. The successful execution of balanced anesthesia is inseparable from continuous, sophisticated monitoring. Examiners frequently ask how monitoring integrates with the pharmacology.
Right. We have to monitor the depth of anesthesia. And since anesthesia is a composite state, we relied on a combination of clinical signs and advanced technology.
Clinically, we use hemodynamic indicators, heart rate, and blood pressure. These reflect the autonomic response to stimulation and help us index the balance between hypnotic depth and surgical trauma.
So what's the principle there?
The crucial principle here is that intense surgical stimulation reduces the level of sedation. This necessitates an increase in hypnotic dosing to keep the patient in the safe zone and avoid the ultimate pitfall.
But relying on HR and BP alone has limitations, especially in patients on beta blockers. And that's why we rely on EEG-based monitors.
Exactly. Processed EEG-based monitors, like the bispectral index, or BIS, provide a continuous index of the effect of the hypnotic drug concentration on cortical activity. The goal is individualized, precision drug delivery.
To estimate the risk of consciousness.
To estimate the risk of conscious experience. These monitors are critical for preventing awareness under anesthesia, or AUA, particularly in high-risk scenarios like trauma or cardiac surgery where we're forced to run very low hypnotic concentrations.
That risk of awareness is terrifying. I imagine that's why the discussion around depth monitoring is so emotional. It's not just physiology, it's a profound ethical failure if it happens.
It is a profound patient safety and ethical concern. AUA, although rare, is one of the most serious complications of BA. We prevent it by adhering to standard dosing, ensuring meticulous monitoring of drug delivery systems, especially in TIVA,
And using the technology we have.
and using EEG-based devices to confirm adequate hypnotic depth, keeping the BIS typically between 40 and 60.
Moving to the physical state, we must monitor muscle relaxation and avoid residual neuromuscular blockade, or RNB.
RNB is a preventable complication that impairs respiratory function and airway protection post-surgery. We quantify the degree of motor block using a nerve stimulator, but the clinical assessment uses the Bromage scale.
You have to know its criteria for exams.
You do. Scale 0 represents no block. The patient can freely move their legs and raise an extended leg. Scale 3 represents the most severe block, the inability to move the leg, flex the knee or ankle, or move the toes. We aim for a reversal that ensures a scale of 0 before extubation.
Finally, a nuanced understanding required for complex scenarios. Differential blockade, specifically in regional anesthesia.
This is the classic differential detail. The principle is neurobiological. Smaller, typically myelinated nerve fibers are inherently easier to block with local anesthetics than larger ones.
Can we detail the order of sensitivity from most to least sensitive?
Of course, start with the most sensitive. B fibers. These are small, minimally myelinated preganglionic sympathetic fibers. They're responsible for sympathetic tone, vasomotor control, and cold sensation.
Okay.
Then you have A delta fibers carrying fast, sharp pain and temperature. After that, A gamma for muscle spindle tone, then A beta for touch and pressure, and finally A alpha, the largest and most resistant fibers, which carry motor function.
We often see patients in recovery who can move their toes but can't feel the cold on their leg. What specific neurobiology explains this weird separation of function?
That is the clinical manifestation of this differential blockade. Because B fibers, sympathetic and cold, are blocked most easily, the level of sympathetic block, which you assess by loss of cold sensation, may extend 1 to 2 segments higher on the patient's body than the level of pinprick block,
And that's higher than the motor block.
which in turn is higher than the level of touch and motor block. This shows that sympathetic activity is blocked first, then pain, and finally motor function. This knowledge dictates how we assess the spread and safety of regional techniques. Balanced anesthesia is not a rigid formula. It's a philosophy that requires modification based on the patient's unique pathology and the surgical requirements.
Let's start with the cardiac patient, often undergoing high-stress procedures like aortic reconstruction. The primary goal there is myocardial protection.
The overriding goal is maintenance of stable hemodynamics and ensuring a constant favorable balance between myocardial oxygen demand and supply. The standard BA technique opioid plus a low to moderate volatile agent is often used.
Why that combination?
Because modern volatile agents, Isoflurane specifically, have demonstrated beneficial myocardial protective effects or preconditioning while maintaining stability.
But patients with severe left ventricular dysfunction often necessitate a drastic modification.
Correct. Patients with severely compromised cardiac function may require a pure opioid technique using high-dose fentanyl or sufentanil, often up to 50 to 100 mics per kilo.
And that's chosen for stability.
It's chosen specifically because opioids, in isolation, cause minimal myocardial depression and maintain exceptionally stable hemodynamics while powerfully blunting the stress response.
But there's a trade-off.
The critical trade-off is that this technique causes severe respiratory depression and necessitates prolonged post-operative mechanical ventilation, sometimes for days.
What's the role of regional adjuncts in this group?
High thoracic epidural or spinal analgesia combined with GA is strongly advocated for major vascular surgery. This combination provides excellent opioid sparing and the strongest inhibition of the surgical stress response.
But it's limited.
It is heavily limited by the pervasive fear of epidural hematoma in patients requiring systemic anticoagulation during and immediately after surgery.
Okay, switching gears to neurosurgery. The awake craniotomy presents a conceptual paradox to GA.
This is perhaps the ultimate test of the BA philosophy. The goal is a smooth, safe, rapid transition between deep anesthesia for opening and closing and full consciousness for brain mapping.
And homeostasis is everything.
Homeostasis is paramount. Stable hemodynamics and maintaining normal intracranial pressure, or ICP, are non-negotiable.
The anesthetic technique in the awake phase relies heavily on monitored anesthesia care, or MAC.
That's right. And the MAC component requires absolutely excellent regional anesthesia of the scalp. Inadequate local block cannot be overcome by sedation.
What are the drugs of choice?
Highly titratable ultra-short-acting agents, often propofol combined with a remifentanil infusion or a dexmedetomidine infusion supplemented with fentanyl boluses.
Why dexmedetomidine?
Dexmedetomidine is favored because it provides a unique form of arousable sedation that interferes minimally with intraoperative neurological mapping and monitoring.
I recall the specific 622 mixture. What makes this novel approach so effective for targeted moderate sedation?
The 622 mixture is a fascinating example of optimized synergy for DESCI. It combines propofol, a short-acting opioid like alfentanil, and 1% lidocaine in a single syringe, titrated to moderate sedation.
What's the lidocaine for?
The addition of lidocaine helps stabilize the local vessel response to propofol and reduces pain on injection. This mixture provides superb analgesia and hemodynamic stability with minimal respiratory or airway support needs. It's ideal for regional blocks or day surgery.
Finally, pediatric and burn patients. These require rigorous physiological goals linked directly to Pillar 6, homeostasis.
Absolutely. The goals are maintaining robust cardiopulmonary function, providing profound residual analgesia, and aggressively conserving body heat.
How does that change the technique?
In neonates, high-dose opioids are poorly tolerated due to potential respiratory depression, so the BA maintenance often relies on a small dose of fentanyl with a volatile agent in an O2 air mix.
And the shift in volatile agent selection here is significant.
It is. Isoflurane has almost entirely replaced halothane in pediatric practice. The rationale is better patient acceptability, rapid induction in emergence, a lower incidence of laryngeal irritability, and fewer cardiovascular side effects.
And for burn patients?
For burn patients who have massive surface area heat loss, rigorous temperature control is non-negotiable. This involves mandatory temperature monitoring and the use of forced warm air devices. Otherwise, the induced hypothermia dramatically increases morbidity.
Now that we've detailed the science and the technique, let's summarize the inherent advantages of choosing BA as a philosophy. This is often a specific exam question.
The advantages are rooted in the pharmacology. First, reduced drug toxicity. By leveraging synergy, we use less of each agent, avoiding the toxic ceiling of monotherapy.
Right.
Second, hemodynamic stability. Opioids specifically blunt the sympathetic stress response, maintaining a more stable cardiovascular profile. Third, superior analgesia. The integration of potent opioids ensures deep pain relief, not just suppression of consciousness. Fourth, faster and smoother recovery. By minimizing drug accumulation, we ensure a more predictable emergence.
And finally, a reduced risk of awareness.
Fifth, reduced awareness risk.
Mm-hmm.
Because we have multiple agents working on different targets, spinal for immobility, cortex for hypnosis, we build redundancy into the system, reducing the risk of AUA.
Conversely, what are the inevitable disadvantages and complexities introduced by relying on multiple agents?
Well, the primary disadvantage is the inherent complexity of drug interactions. While synergy is desired, unwanted interactions can occur.
Like the benzodiazepine issue.
Exactly. Second, there is a risk of underdosing individual components. If we rely too heavily on the AMC sparing effect of an opioid, we might inadvertently run too light on the hypnotic, leading to awareness.
Or too light on the opioid, leading to a sympathetic surge.
Precisely. And third, the technique requires more meticulous monitoring. We have to track hypnosis, relaxation, and analgesia all at once.
Examiners love comparative questions. How should we contrast BA against its primary competitors?
The three key comparisons are BA versus GA with a single agent, which is more of a historical context, BA versus TIVA for modern technique choice, and BA versus regional anesthesia for modality choice.
Let's start with the historical contrast, BA versus single-agent GA.
This contrast is foundational. Single-agent GA is characterized by massive physiological trespass. Severe hypotension and respiratory depression are mandatory to achieve immobility. BA, through synergy, allows us to achieve surgical depth with relative hemodynamic stability.
So BA is always the choice.
The choice is always BA unless prohibited by extreme circumstance.
How about BA versus TIVA, the volatile versus IV debate?
BA, which is volatile-based, generally offers easier titration and a more immediate reversal, as the agents leave the body quickly via the lungs. TIVA, while offering better VQ matching and less PONV, relies on complex pharmacokinetic models and carries a higher risk of dose accumulation and awareness.
So when would you choose TIVA?
TIVA is preferred when specific surgical monitoring dictates, like with neuromonitoring, whereas BA is the widely accepted standard for general surgery due to its reliability and safety profile.
And finally, BA versus regional anesthesia.
They aren't really true competitors, they're complementary. Regional anesthesia, if it's feasible, provides the best stress attenuation and opioid sparing.
But it doesn't provide everything.
It rarely provides all the necessary components for complex, long procedures. The modern trend is often BA combined with regional techniques to maximize the benefits of both, achieving optimal analgesia and minimal systemic trespass. When reviewing for Aviva, you must be prepared to discuss the complications associated with BA. This demonstrates clinical caution.
The primary complication, as we've discussed, is awareness under anesthesia, AUA.
Correct. It's a critical pitfall, usually resulting from inadequate dosing of the hypnotic agent relative to the surgical stimulation.
And the classic scenarios are
Induction in trauma or cardiac patients, where the dose has to be minimal to preserve blood pressure, or compromised drug delivery like a TIVA failure or a vaporizer running out. Prevention relies on continuous application of all our monitoring metrics.
Another major pitfall is hemodynamic instability, particularly hypotension.
Hypotension is an inherent risk, especially because volatile agents cause vasodilation. The key in BA is to manage this proactively.
How do you do that?
If the patient becomes hypotensive, the clinician has to differentiate the cause. Is it deep hypnosis from too much volatile, or is it hypovolemia? The rationale dictates reducing the volatile agent first, increasing the supportive narcotic component to leverage synergy, and then treating the fluid deficit.
And the risk of inadequate analgesia despite the use of opioids.
This often occurs when the clinician relies solely on systemic opioids without implementing multimodal strategies or regional blocks. It manifests as a sympathetic surge, hypertension, tachycardia, and difficult emergence. The solution is always to reinforce the multimodal approach early.
We've already covered residual neuromuscular blockade, or RNB, but why is it still such a common clinical issue?
It persists because of poor monitoring and failure to adequately reverse the block. RNB occurs when a non-depolarizing block hasn't fully worn off, leading to muscle weakness, compromised airway reflexes, and a high risk of aspiration and respiratory complications.
And the strategy to avoid it.
The definitive clinical strategy is using a nerve stimulator to ensure a train of 4, or TOF ratio greater than 0.9 before extubation. To solidify this deep dive for examination success, we should finalize with the high-yield checkpoints and one-liners that examiners just expect you to know.
Okay, let's pull the key themes into a rapid revision summary segment first.
Here is the necessary framework for rapid recall.
The rationale of BA.
To achieve the 4 cardinal features with minimal physiological trespass by leveraging synergy.
The sites of action.
Immobility is spinal. Amnesia and hypnosis are supraspinal.
The pharmacology.
Volatiles and propofol enhance GABA-A. Opioids suppress the HPA axis. Xenon and nitrous oxide inhibit NMDA. Induction uses an opioid to blunt the intubation response. Maintenance uses low MAC with narcotics for synergy. And homeostasis requires rigorous fluid and temperature control.
And the monitoring.
DIS, or entropy for hypnosis. TOF, or Bronage, for relaxation. And HR and BP for overall stability.
Now let's list the crisp model answers, those one-liners that immediately demonstrate mastery to an examiner.
Absolutely. Wow. Memorize these. 1. Balanced anesthesia is essentially applied drug interactions leveraging synergy.
2.
Immobility, or MAC, is mediated primarily at the spinal cord level, independent of the cortex.
3.
High-dose opioids attenuate the dangerous hypothalamic pituitary adrenal axis stress response.
4.
Multimodal analgesia central goal is always opioid sparing by combining agents with differing modes of action.
5.
Regional anesthesia is the most successful method of reducing the neuroendocrine stress response.
And 6.
The key difference between sedation and GA is that GA requires the disruption of thalamocortical networks.
Those are powerful takeaways. The science of BA is clearly defined through molecular targets, quantified synergy, and pharmacokinetic models. But if synergy is so predictable between hypnotics and opioids, why isn't every BA case identical? What variables challenge that perfect synergy in the OR?
That leads perfectly into our final provocative thought for you, the learner. Despite the immense scientific progress in quantifying synergy, predicting pharmacokinetics via TCI models, and identifying precise molecular targets, the clinician must always titrate to the individual patient's clinical effect.
Why is that?
The reason is the profound inter-individual variation pathophysiology, genetic polymorphisms affecting drug metabolism, age, comorbidities, volume status. The complex, non-monotonically progressive dynamics of the central nervous system under anesthesia means that the perfect clinical sweet spot,
The optimal balance.
the optimal balance between adequate depth and zero physiological trespass, remains elusive. No machine can achieve it. It requires continuous, critical application of knowledge, making clinical anesthesia an art built upon the most rigorous of sciences.
A perfect blend of science and human judgment. Thank you for joining us for this deep dive into the science and strategy of balanced anesthesia.
Study smart, and we look forward to the next deep dive.